Hello, this is Dr. Scott Worden, the TOS guy from beautiful Sunnyvale, California. It's gotten cold here. The winter is coming. I hope everybody is doing well out there. Thank you for coming and viewing. We have a special show today. But first of all, I want to remind you, please subscribe if you haven't already. That really helps us. We're trying to get to our first 1,000 subscribers, which will enable us a lot more rights on YouTube. So please subscribe or get your friends to subscribe if they have seen us. Second is, during our talk, hit the like button. That's a big deal for their algorithm to decide that we're important enough. So hit the like button, get your friends, your dog, your cat to hit the like button. Today, we have a really unique guest, Dr. James Avery. I think anybody with TOS in the Western United States has probably heard of Dr. Avery. And if they hadn't, it's because I haven't mentioned it because I'm always bragging on this guy. Jim, welcome to the show. It's really great to have you here.
Thanks, Scott. Nice to be here.
I'm going to ask you to introduce yourselves, give us a basic idea of your CV from where you started, which is pretty extensive, and let us know where you are now.
Okie doke. Well, I went to college at Yale and medical school at Columbia, and then did a residency in general surgery, followed by some more surgical residency in cardiothoracic. So I'm trained as a heart surgeon. And you might ask, how does a heart surgeon get involved in this procedure or this subject, which largely has been traditionally handled by vascular surgeons? And the reason was, and I have only one person to blame, and that's an excellent man by the name of Tracy Newkirk, who approached me in 2002 because he was dissatisfied with what was being done locally in terms of the adequacy of the surgery for this condition. So at the time, I was in a kind of lull in the cardiac surgery world for a variety of reasons locally. And so I had time to get kind of immersed in this at that interval of my career. And this again is 2002. So it's now 21 years ago. And I then looked at the literature and tried to figure out what would be an appropriate surgical approach to avoid recurrences, mainly because recurrences were pretty common. And that embarked, from that, I embarked on a journey to treat this condition, which for the first 10 years, I did in a particularly, I would call thorough and aggressive manner until about 2012, roughly 10 years later, when I discovered to my surprise in helping a vascular surgeon actually do a vascular case, which happened to involve a subclavian vein occlusion. I was really stunned to see how much I could access the first rib from an infraclavicular incision alone. Prior to that, I had done a big operation in which involved an incision above the clavicle, kind of in a traditional fashion, and then added an infraclavicular component. And at that time, I was thinking that this would be uh, most effective were I to take out all of the scalene muscles and all of the first rib and really have the nerve roots, all five of them in the brachial plexus, C5 through T1, hanging in the breeze, thinking that that would be a way of making sure there was nothing that was exerting pressure on these structures. And I was wrapping the nerves in this material that was said to be helpful in reducing scar tissue adhesions, which was a problem. And that worked out pretty well when it did. But unfortunately, it was sort of unpredictable in the sense of who would have function immediately post-op. So I got a new approach based on an observation after doing this for 10 years that from an infraclavicular approach below the clavicle, one could get far enough back to do what I considered to be an effective removal of the rib, which was to remove the bottom of this bone on bone vise that some people have as a functional problem.
Now, this
That's
started in 2012, correct?
2012. That's right.
And so you've done a group of patients before that and a group of patients after that.
Yes.
I
And
want to
they
get back to that in a little bit because I have an outline of questions, and because of your rich history, you've got so much to tell. We have to figure out how to get it into a short show. Where are you right now, and what's your official title?
right now I'm in San Francisco at California Pacific Medical Center, where I function mainly as a heart surgeon, and in particular, as I'm in the tail end of my career, I'm an assistant only on the routine cases like we did earlier today. On the other hand, when transplants happen, which we do so far 24 this year, then I will jump into the plane and go procure the heart and bring it back for my other two colleagues to implant the thing. In the early days of doing transplant, I was fortunate to be able to do both ends when it was required, but it's gotten a little more organized now so that kind of um, wild and crazy stuff isn't going on anymore. But it was always a satisfying thing, and we did our first in 1984. So
Wow.
that's
40, is that
currently
40 years?
well, yeah, that's right.
Wow. So heart transplants are amazing. You must feel incredible saving somebody's life like that.
It's probably the most satisfying thing I have done in my life. And every time as I'm driving home, it amazes me that we can take a heart out of one person and put it in another person and have the thing work.
It's incredible to me. How did you learn to do that?
Well, that was a medical school thing that was my first introduction, and that was in the very early stages of transplantation, where we didn't know how to diagnose rejection, and the immune suppression drugs were terrible. And it was only after the introduction of two things that the results got better. One was the better immune suppression drugs, cyclosporin, and the other was endomyocardial biopsy, which allowed us to know when rejection was beginning to happen so we could nip it in the bud rather than wait as we used to before this time for there to be some outward or external
Cardiac.
marker of rejection. That was too late.
This may be something you don't know, but my understanding was that the first heart transplant ever in the world, Dr. Christian Barnard, that he knew it was going to be rejected and he went ahead and did it anyway.
That could be true. He actually was in Palo Alto, or actually, it was in San Francisco because Stanford used to be here, and Norm Shumway was working in the lab here at CPMC. And then when about half of the faculty moved from this facility, which used to be Stanford, to Palo Alto, Norm went as well, and he did all the lab work, so to speak, the bench work, to figure out how to do it as a mechanical thing. And Barnard basically stole the information, ran down to South Africa, did the first one, and it was sort of a big deal. But that was sort of the end of his career too, because then he went off into the weeds of other pursuits.
Wow. So he was here? I didn't know
He
that.
he was yeah, he came to work with and to see what Norm Shumway was doing at our facility, and then he ran home and did it in South Africa.
So at the time, people were not doing them here, not for mechanical reasons of the procedure, but because of these other factors?
The other factors, yes, and the mechanics were worked out, as I say, by Norm in the lab here. And what was waiting was the evolution of better immune suppression medicines, as well as a way of figuring out rejection with the endomyocardial biopsy early in the course when it was much more successfully treated.
Wow, that is really cool. Think about where it is today.
Yeah.
Cool. So let's go back a step. So when you started TOS, uh, Tracy Newkirk approached you, and what did you know at that point about TOS?
I thought of it probably mostly as an arterial disease because that's what was taught in medical school. And I think, unfortunately, that was the case for most doctors. It was appalling to me that people had the attitude that if I can't find it, it being a diagnosis that this patient has who's got a normal neurologic exam but is complaining of nerve symptoms in the arms
Mm.
with their hands and arms in certain positions. The attitude was very common that if I can't diagnose it, it doesn't exist. And I'm sure patients out there, some of whom have heard, probably most of whom have heard from a variety of doctors before they get to a person who does believe this thing is real. It's not um, imaginary and it's not made up. Before you get to that sort of an individual, you hear that you don't have anything wrong with you, and it must be very disappointing, to say the least, to the patient to hear that the thing they're suffering with isn't an entity, but that was the prevailing attitude at the time. There were people even back then that believed in it, and Dick Sanders was one of them, a surgeon in Colorado, whom you and I both visited early on in the career, as I was wanting to see how the guy who wrote the book, uh, approached this. And he did a fairly standard supraclavicular approach. So that's why I did that at the beginning. And as I mentioned, the only reason I changed was that the operation that I did, which was a lovely exposure that took 5 hours, and all the people in the room loved to see it because no one had ever seen that area of the body exposed in that way.
Hmm.
I could never tell whose arm was going to work, and it was just agonizing for me
This
and
is
the patient.
the
The
supraclavicular approach.
supraclavicular, where all the nerve roots were hanging out in the breeze, and
Yeah.
I was exposing the phrenic and all this kind of jazz. So
Yeah.
there were a lot of nerves involved, and it turned out to be um, a big question mark as to who was going to have arm and hand function immediately upon awakening from the operation. Fortunately, people's uh, their function resumed, but it was unpredictable. And while we were waiting for the nerve um, uh, resumption to occur, and I'm not talking about division of nerves, but just severe inflammation primarily from the exposure and the
Mhm.
manipulation required in that operation.
Now,
And that's
you
one.
may not remember this as well as I do, but in one of the many surgeries I've gotten the chance to observe that you performed, the very first one, you were showing me how careful you were with the phrenic nerve, and you were like, "Don't touch it, don't breathe on it, don't even look at it." It was so delicate that it couldn't be
Yes.
disrupted, or the heavy diaphragm would be paralyzed,
Yeah, and
and
it,
patients
it's
would have trouble breathing.
and
So
you may
to
recall. You
so to a
excuse me.
lesser extent, that happens with the remainder of the brachial plexus.
That's right. And you may recall the phrenic itself looks like the size of a pencil lead, and yet it's one of the crucial ways that the way that the diaphragms are innervated.
Yep, I remember that very well. Um, so you started with TOS, and you brought up an interesting point that it was mostly done by vascular surgeons, and to some extent, some of the largest published publication artists, authors, some of the people who have the biggest names in the field right now are vascular surgeons because that's their territory. But for my
Correct.
2 cents, it's a different disease. So they know the anatomy, they know the anatomic area, which you call tiger country because it's so complex. And I've told people that. And so it's taken some time and evolution for other specialties to get into it. But also, there are people like you who have learned within the field, starting out acting as a vascular surgeon. You've now taken the new approach. So let's talk about that in a little detail. About 10 years ago, you decided you would take this infraclavicular approach, and it was because a vascular surgeon was doing it for a different reason.
Yes, and again, I was so surprised to find that coming into that region of the body from under the clavicle, that one could expose the first rib adequately enough to be able to get the portion of the first rib which acts like the bottom of the bony vise. And if I
Mm.
could use my fingers as prompts here, um,
Do you want an image?
oh,
There
that's
we go.
even better. That's fantastic. What I'm looking at in this image is one of the netter drawings, as you can tell by the style and the age of the drawing, but I think there's no image that is more beautifully drawn, with one exception that I'll mention in a moment. But what I was um, surprised to find is that the incision below the clavicle allows me to transect the first rib through the cartilage bridge using a Carrison rongeur, which is a neurosurgical instrument. And then with that detachment in the front, I could move the rib laterally and medially and expose intercostal muscles that attach to it, as well as some ligaments on the inside curve of the first rib, and get all the way back to where the first rib has approximately a 90-degree turn from being an anterior posterior orientation and a fairly straight, flat bone to a right angle turn when the bone is reattaching itself to the top of the first thoracic vertebral body, T1. So if one goes that far back, in my opinion, that's adequate in the sense that what we're trying to do with the surgical approach to this condition is eliminate the compression that can happen between the clavicle above and the underlying first rib. And keep in mind that all the ribs are oriented in the same way, namely high in the back and low in the front. And as the clavicle sitting on top of that first rib moves back, which it will do because it's hinged in the front where it attaches to the top of the sternum called the manubrial body, allowing the shoulder that's firmly attached the clavicle to the acromion process of the shoulder blade, that clavicle is going to be moving posteriorly when I move my arm as I am now, preparing, say, to throw a ball. My clavicle is moving toward the back of my body as much as it possibly can by that action of my shoulder and arm. And when the clavicle gets close enough to that underlying first rib, it will compress what's between the two. And what's under there is a vein, the dark blue subclavian vein, an artery, the bright red subclavian artery, and some yellow things, which are nerve roots. And the only thing I would call to Dr. Uh, Netter's attention, were he still alive, is that he put the nerves way too low. And I can tell you, just based on seeing this about 100 times in the operating room, that when we look at the back of this drawing where we have a first rib started to pass underneath what is the middle scalene muscle, one of those red muscles, uh, at that point, we now typically would see the T1 nerve root coming up from the inside curve of that first rib,
Mhm.
again, near the middle scalene muscle. And C8 would be lying right across the head of that rib. And so the point being that the further back you get coming from the infraclavicular approach, the closer you get to the nerves. And I learned from that first 10-year experience that one of the things I don't want to do is expose the nerves, because any exposure of a nerve is like any exposure of any part of the body. Healing involves the creation and formation of scar tissue. And when you have a nerve that has been cemented to its next door neighbors, soft tissue, then every time you move your shoulder or arm, you have the potential for triggering a nerve symptom because the nerve is going to be tugged rather than sliding, which it typically would do. But in the presence of adhesions, it becomes stuck. And so you'd like not to have any exposure to the nerves, ideally, because then you avoid scar tissue formation. You also avoid the potential for injury to the nerve. But I think more importantly in this context is that you don't elicit this healing reaction because you haven't exposed it, and therefore the nerve slides and it doesn't trigger nerve symptoms.
Now
So
I'm going to bring up I'm going to climb up my soapbox temporarily because there are many publications out there by, again, some of the big names in vascular surgery who, as part of their standard procedure, do an aggressive neurolysis. That they believe there's scar tissue forming around the outside of the nerves, and so they kind of strip down the nerves. This is exactly the opposite of what you're saying, and you've got decades of experience. So um, I don't need a comment from you unless you want to, but I can tell you that I've seen post-op MRIs with very inflamed brachial plexus components. And
yes, that's quite right. And I have done a couple of neurolysis procedures myself on patients when I thought maybe it would help, but I'm convinced that it doesn't. And the reason it doesn't help is that, as I just mentioned, when the when the body is healing any kind of a wound, and surgery is a controlled wound, obviously, scar tissue formation will happen. It's part of the reason that we can survive, and was evolutionary, for evolutionary reasons, very important that wounds would contract, and scar tissue was involved in that. But in this context, having scar tissue is not a good thing, and it always comes back. So if you do a neurolysis, that may work for a few weeks or months, but it's not going to be a sustained improvement unless you can eliminate scar tissue, and nobody's quite figured out how to do that.
we also know that a lot of TOS surgeons hate redos. Once a patient has had surgery, without symptoms improving or with recurrent symptoms, if a surgeon has to go back in, they know they're going to face a minefield of scar tissue.
Yes, and the danger of injuring a nerve really goes up under those
Huh.
circumstances. So it is I would caution anybody who wants to get into this surgical world is to really try to avoid exposing nerves, however you do the operation, because it will always be a headache, and the danger of a re-op is real.
So, Jim, now I want to ask you a couple technical questions about when you do this. You are automatically getting most or all of the first costal cartilage, the first rib cartilage, correct?
Yes.
And when you march backwards, you've told me in the past you go far enough back that you could put your finger there and move the arm and assess whether you've cleared up the compression.
Yes, that's how I assess whether in the operating room I've done enough to eliminate any contact between the clavicle and the residual first rib by having the patient's arm, let's say it's the right side we're doing. So the patient's right arm would be in a sterile sleeve. It's part of the prep and drape of the operation. And I would put that sterile sleeve on the patient's abdomen and secure it there temporarily while I'm doing the operation. And when I've reached the point of thinking I've done enough surgery, and what I'm doing is I'm looking through an access of about this much space. So
Mm.
I'm using a neurosurgical instrument, a rongeur, which is a radial-based instrument, meaning it's a long, thin tube with a pistol grip on one side and a Pac-Man like biting apparatus. Let me get it in the screen. A little biting apparatus at the distal end of the instrument, so I can see around the instrument. That's the point, because it's a small space I'm working in. Yet I want to be absolutely sure when I bite something down with this instrument. And by the way, I'm removing the rib not as a single entity, but as piecemeal, little bites. And then I just keep biting my way like a Pac Man type thing toward from the front to the back until I've removed what I think is enough rib. And at that point, I put my finger on the stump of the rib. So I'm under the patient's clavicle and I'm moving the right arm up and back as I'm demonstrating right now. And I do that because that's the most provocative position one can be in, moving the clavicle as far posteriorly as it can go anatomically. And if in that position there is no contact between the clavicle and the first rib, I stop. If there is contact and I'm feeling it with my fingertip, then I take a little more rib. And that's the part of the operation that I have learned to be very gentle with in terms of the retraction. And that is to say, in order to see at the bottom of this small space, one has to lift up a bit using what's it's called a brain retractor. Literally, it's a very flimsy aluminum flexible retractor about half an inch wide and about 3 or 4 inches long, not at all complicated, but it just allows you to just gently lift up what's in the back, which is going to be T1 at the
Mhm.
bottom of the five and C8 next door. They travel as a pair, usually all the way down as the posterior cord, which becomes your ulnar nerve. So I'm trying to just lift up the nerve enough to be able to see distinction between bone and non-bone before I take the last little bit. So I'm very cautious throughout the whole operation, but especially so when I'm getting very close to the back where I know the nerves are going to be, but I don't want to see them. I want to stay away from them. So in this approach, I'm going under everything. I'm going under the subclavian vein, which sits right under the clavicle, under the subclavian artery, which loops up a good bit higher than we normally see from the textbooks. And then finally, the brachial plexus nerve roots, C5 to T1. And the ones I'm going to encounter, as I mentioned, are T1 at the bottom and C8 coming next. So
Now,
I
by
know I'm in that region, but I got to really take it easy and guard against trying to do too much.
by necessity, this means you're doing an anterior scalenotomy, releasing it from the first rib.
Yes, I come upon the scalene muscles, which I'm going to detach from the first rib. First, the anterior scalene, as you mentioned, and then a little further back. I see very clearly these muscles. They look like kind of a strip of bacon under high tension.
Mm.
And the anterior scalene first, and I use what's called a bipolar cautery to do the so-called cutting. This is electrical current, but very specific at literally a pinpoint as opposed to a usual Bovie, which is a machine that you press one little button and a whole lot of electricity is delivered to the tip of the instrument. It's kind of like a shotgun versus a rifle. The bipolar is much more precise, and that's the rifle side of the equation. And I use that instrument to do all the work, releasing intercostal muscles, releasing scalenes. And
Mhm.
the first scalene, as we were just saying, that I encounter is the anterior scalene. And once I divide that with the bipolar at its attachment to the bone, it's like a rubber band under tension.
Mm.
If you have a rubber band under tension, you cut one end, the rubber band whoop, retracts right back up to where it's attached, as happens with the anterior and middle scalene muscles, which are still attached to the transverse processes of the cervical spine.
Mm.
But we found from an early experience, you may remember, Scott, in a woman that we were doing a venous um, approach because she had an unusual neurologic condition with inadequate venous drainage. And we re-imaged her 3 months later and found that the scalene muscles had largely atrophied in the neck and they'd just
Mm.
kind of gone away. Something that also happens with the pectoralis minor that I've come to learn is an important component to take care of too. It is a coracoid process attachment and comes across the neurovascular bundle in the
Mhm.
armpit, attaching to ribs 3, 4, and 5. It also is under tension, and that is a clinical diagnosis you make going into it. And then with imaging, we can verify indeed that there is effacement going on underneath that muscle, and therefore it's playing a role. And that muscle also is under tension and retracts back on to the chest wall when it's divided.
So the anterior scalene, when you finally bipolar, you remove it, it retracts upwards towards the ear. And
Yes,
the pec minor, when you remove it from the coracoid process, that retracts downwards towards the ribs.
yes, toward the chest cage. That's right.
So, compared to the supraclavicular, to make it clear for our viewers, the supraclavicular approach that many doctors take is they take away 2/3 or more of the anterior scalene by dissecting around the nerve roots, which is something you've learned not to do.
Yes, well, as a matter of fact, it's one of those things that you don't really know anything about before you get into the subject, and that is that it's usual, and this was from my experience of 10 years of doing this, to see C5 and C6 going through the body of the
Yep.
anterior scalene. It's not just near there. Frank Netter, in his drawings, bless his heart, always does simplify things for good reason. It's easier to learn it initially, and then you get into the actual anatomy and the details are a little more complicated, and we're all,
Right.
as you know, we all have the same stuff, but the details of how it's arranged is quite a bit different from one person to the
You
next. But
you
what you can
you're
count on,
technically your microphone cut out for a second, so you were saying the anatomy books always show it as the nerves going between the 2 muscles, but that's not
yeah,
reality.
and that's not reality. The nerves are going through the muscle, or it would be extremely unusual for that not to be true. C5, very typical. C5 and 6 often, and 7 often was going through the middle scalene. So the idea is you can't just go whopping through the scalene muscle without first peeling it back to see if there's a nerve underneath, and if so, you have to kind of um, extract the muscle from around the nerve, and that's the kind of manipulation that makes the nerve very unhappy. Swelling, not injuring it like cutting across it, but it disturbs it a lot, and it's best not to do that at all, in my opinion.
So looking back now, one of the questions I wanted to ask you is, you've been doing the 2 approaches for 2 decades. What is your retrospective comparison of the procedure, how the patients do immediately, how the patients do long term?
I think in terms of long term, it's probably the newer approach is probably better. Certainly, the immediate in the recovery room evaluation is now productive. It's predictable rather, and it's reassuring that at the end of the operation, the patient is going to move their hands and arm. And the only thing that the patients tell me about that's a new issue and it's a new symptom, but it's fortunately not a functional issue, is that they will have sometimes a patch of numbness in their forearm area. I'm just going to outline on my own forearm in this kind of region of the forearm. And that's, I'm sure, from retraction of the T1C8 compo, and it's an ulnar nerve distribution kind of sensory dysesthesia that goes away typically after a few weeks. Some
Hmm.
people have none of that other than incisional pain, And one of the things that I make a big point about is to get the shoulder moving right away so as to eliminate and prevent a frozen shoulder, which can be a monster problem to get treated. So it's best avoided.
Excellent. Um, what do you think? What are the changes in the diagnostic approach you've taken over your career? How have things changed? Uh, and how confident do you feel on making the diagnosis?
Well, I have come to rely on your imaging approach, Scott, so much that I am very reluctant. It's happened a few times because of certain details, but I am very reluctant to go forward with an operation without the confidence that I get from seeing the results of your scans. Namely, to see that when the patients are in the scanner with their arms elevated, hyperabduction, there is bone on bone proximity, and in some cases, severe proximity, closeness, that the two bones are acting like a vice. And there's evidence that is not somebody's interpretation, but just it's there of effacement, which, as you know, is a generic term that indicates any kind of physical pressure on any nerve in the body. It's real, and radiologists are trained to see it, but they're not trained to see effacement of these nerves, nor do they understand, a lot of them, that in order to elicit this problem and to, in effect, prove that it's there, one needs to move the arms while the image is being done. And I needn't tell you that everybody in their arms with their arms down who hasn't had a birth injury is going to have normal plexus looking images. But
Totally.
it's only when you, well, as you know, we'd like to be in this position, arms up, stick them up position, because
Yep.
it's the most provocative, but we can't fit in the scanner in that position. So
Right.
at least the compromise of hyperabduction moves the clavicles back a bit. I think it underestimates what's really going on in the real world with that patient, but at least it's
I agree.
showing that even in a compromised, provocative position with the arms up, there is evidence when people have this condition, and you can show this very well, evidence of effacement. When the arms are in that position, the bones are getting close enough together that they're squishing the nerve roots. That's the thing I really care about in terms of having no anxiety about bringing a patient to the operating room who doesn't have the condition. And and as I said, I have only on a handful of occasions and now over 200 patients total of
Mm.
having doing an operation without your imaging study. I now feel that that is a sine qua non for a successful outcome.
That's great. I don't have to toot my own my own horn because you did it so nicely. Thank you for that. We are proud of the work we do, and we think it's really based on a lot of our experience working with people like you. As you know, when we discuss patients, we always get way down into the nitty gritty. And I have a firm belief that TOS is not low hanging fruit, that most patients need a team, doctors who work together, because it's just too complex for a single doc in most cases to figure out and treat. It's
Yep.
my 2 cents. And so I want to thank you because for decades I've had the chance to have resources like you and Dr. Newkirk and other people around the country to learn from. Um, so let me ask you this. When you examine a patient, what do you think, after your full evaluation, is the best predictive factor for whether they'll do well with surgery?
How long they've had the condition. I think the patient who has had these symptoms, and I'm talking about nerve pains and when they do certain things, arms in certain positions and so on, could be constant numbness and tingling, anything nervy. If those symptoms are a year or two old when they are diagnosed, worked up with an imaging study, and then presented to a surgeon, do you think it's going to help? Blah, blah, blah. I go into that surgery with the expectation, quite frankly, that things are going to do well. And I want to make a distinction between doing well from a nerve vessel point of view, which is really what the operation does, as opposed to doing well from the total package
Mm,
point of view. And that gets
mm,
in to my belief that TOS is really a front and back issue. And the front side of the story is what we've been talking about, nerves and vessels coming out of the neck, going in through the scalene triangle, under the clavicle, over to the shoulder and down the arm. That's what the operation that I'm describing, that I've been doing and have been advocating, that's what that operation is treating, that part of the problem. The back half of the problem is a guarding response that I think develops virtually always, especially after years and years of having this problem, which is shrugging, where the shoulders come up and forward. And it's, I think, the expression of the inherent guarding instinct that we all have as humans. And the example I like to use with patients is to say, well, what would happen if you or I were walking on on a sidewalk that was uneven and we tripped, we fell forward, landed on our hands, and broke our wrist? We got a Colles fracture, let's say, without thinking, without any cognition. The instinct in all of us is to surround and protect, cradle the arm, surround and protect the hurt part. And I think what shrugging is doing is the body is trying to protect the hurt part, which is brachial plexus nerve roots coming out more or less from the front of the body. It's in the neck, in the middle, and I know the spinal cord is in the back, but those nerves wrap around from the back and come to the front, and they're more or less coming to the front of the body. So if the pain is originating from the anterior portion of the upper body, the shoulders up and forward, I think, are just responding by trying to surround and protect the hurt part. Unfortunately, that becomes such a deep muscle memory that the patient doesn't even notice they're doing it, first of all, or understand why there's always this pain in my upper trapezius. It turns out the upper trap, levator scapulae, rhomboid minor, those are the three muscles which we have nicknamed the shruggers, and they are the ones primarily responsible for lifting the shoulder. And the pectoralis minor is one of the ones involved with pulling things forward, which, as I
Mhm.
mentioned earlier, I've become more tuned into the fact that that's an important thing to evaluate. And if it's a part of the problem, definitely take care of, because there have been a couple of cases before I got this level of awareness of the pec minor who had to have a pec minor after a successful rib, because and this usually would be in people who are techies. They'd go back to their computer and
Mhm.
with their arms forward, their arm would get suffused because the subclavian vein was being compressed by the pec minor with the arm in the anterior uh, uh, keyboard position. So now I really look for that, and if it's there, I do it at the time of the rib operation so that there won't be any further mechanical compression of anything post-op.
So basically, two steps of healing. One is the decompression, and the second is the returning the muscles and posture to normal.
Yes, and that feature is extremely difficult to treat without this posture vest that Tracy invented. And uh, I'd say that it's not for everybody because not everybody can tolerate it. But boy, when it works, it really is effective. And it's the only thing in my experience, that does anything meaningful. And by that, I mean that the muscle relaxants never work. Botox temporarily might, massage helps at the moment, soaking and all the usual stuff that physical therapists like to do is fine, but it isn't more really than a temporary fix. And
So
what you'd like to
Botox has not had good results for you.
Botox is variable. Sometimes people get worse, and if it works, it doesn't stay working for more than about 3 months.
Yeah.
So it's something that doesn't have a ring of real effectiveness in my book. And this vest that Tracy uh, fashion called the Body Boy was very successful when it's tolerated by the patient. And he and I see a little different approach to using it. I'm more sequential, nuanced, little bit at a time, pulling back, because what it does is pulls the shoulders down and back. And what we're trying to do with whatever the approach is to undo the deep muscle memory that's evolved, which is I'm going to demonstrate shrugging, and replace that deep muscle memory with a more relaxed deep muscle memory. That's the goal, but it doesn't always happen.
So
And
Dr.
and
Newkirk's approach is even pre-op to try to reposition the shoulders.
yeah,
But
and
by your theory that you have to decompress, then that's not going to get rid of that primary problem.
yes, and unfortunately, when the muscle component, the shrugging component, doesn't get better, and for a variety of reasons, then the patient's perception of the operation is that my computer just shut down.
We're with you. I can hear you. Oh, I think we're frozen here. All right, we'll let Jim sign in again. Hopefully, it should be soon. And I'm going to take a couple of questions here if we have a question or two. Actually, I'm going to wait on that because um, Jim might want to answer some questions and our viewers might want Jim to answer the questions. So, what we've been talking about with Dr. Avery, and I want to complete this question, is what's a good predictive factor? What does he believe is the best predictive factor for a good outcome? And he talked about patients coming to see him without a long delay, 1 to 2 years. And this is something we here at Vanguard Specialty Imaging have emphasized. We believe that the diagnosis um, needs to be made early, but that won't happen with a lot of patients. And I'm sure the viewers know this, that they go to see doctors, and the first or second or third doctor may not know anything about TOS and maybe hasn't even heard of it. So that's where certain things like social media can raise awareness. While it doesn't treat it, it certainly raises awareness and then allows people to search for help on the web. And one of the things we offer on our website is a lot of education about TOS. So hopefully, you as a patient, if you do have it, you can advocate for yourself when you go to see your doctor until he or she says, okay, I'll read a little bit about it, I'll figure it out, or I'll refer you to my colleague, a specialist who does know about it. So again, we emphasize here to advocate for yourself, and that's through gaining some knowledge, which is now readily available. We all know Dr. Google, even I search sometimes rather than a textbook. And then to, armed with that knowledge, work with your doctor to find the right knowledgeable resource to help you figure out whether it is or isn't TOS. And of course, we believe in what we do here. So our scan, we believe in the right patient, is an important part of that. We believe that it helps either confirm or rule out TOS as necessary so you can be treated for TOS or treated for the other condition that is there and causing similar symptoms. Hey, Jim.
Hi, I'm
All
back.
right, good. You're
Sorry
back.
about that.
So let's go back to the predictive factor. You said patients you see that have had the symptoms, nerve symptoms for 1 or 2 years,
Hmm.
you're pretty confident. And you're saying that patients who have had longer symptom existence without being diagnosed, those are more challenging.
Definitely. They are less likely to have a spectacularly good result. I think everybody feels somewhat better in some ways, not everybody, but for the most part, people are improved. And again, the thing that I think influences their perception of success is heavily tied to the shrugger muscle problem. In other words, if that doesn't get better, they're still walking around with pain in their muscle a lot, and life is just not good. So it's I think it's important to address that, and probably the body buoy is the one thing that can work. And so
By
it's
Dr.
something
Newkirk.
that
Yeah.
Dr. Newkirk's
Yep.
device. Yeah, it's an
So
orthosis.
why do you think some patients get to that point of beyond 2 years without a diagnosis?
Well, probably they've been going to doctors who haven't been able to make the diagnosis or don't feel like thoracic outlet syndrome exists in the first place. And so they are kind of either not diagnosed or misdiagnosed, and people will have uh, operations that may be a carpal tunnel release or an
Right.
ulnar nerve transposition or something like that, when indeed the problem's coming from up in the brachial plexus area, not more peripherally. So I think that situation was very common when I'd see patients in the first part of my career of TOS surgery, that they'd had a lot of operations, none of which did anything for them more distally because it wasn't recognized that the problem was up top. And again, I think doctors, to give them a little bit of a break here, were taught in medical school the Adson maneuver and TOS, and it was associated with the diagnosis. And that's an arterial problem, as you know, which is really only about 2% of the total population, whereas about 95% of the population of people who have thoracic outlet syndrome have neurologic symptoms, not vessels symptoms.
Right.
Subclavian vein occlusion is dramatic as can be because the arm turns purple, gets swollen, and you think you're going to die. That's very obvious, but
We don't see those
that's
patients. They go to the ER.
yeah,
Yeah.
and they get lysed and things get better, and then they may see somebody to get the first rib removed
Right. So
and
that's a
prevent a
great
recurrence.
the way you put that. Yeah. The AdSense maneuver, Adson was brilliant, and But in the 1920s, that's what he had. He didn't have MRIs or CAT scans.
Yeah,
And
and he was
so,
right. That anterior scalene, which is an accessory breathing muscle, not anything relating to strength in the neck. I want to point that out to people who are considering
mm,
this, and that is that, well, if you take those scalene muscles, they look like they're important structurally, right? They're going for the first rib and they insert in the neck on the transverse processes. But indeed, they're just functioning like intercostals to flare the rib cage. So if diaphragm breathing provided by the phrenic nerve isn't enough, which is what you and I are using to breathe right now because we're quiet sitting around talking. If that isn't enough, then you add chest wall
mhm,
expansion, and that's
mhm.
intercostal nerve, and or rather intercostal muscle function to expand the rib cage and create more volume exchange.
Actually, embryologically, don't ask me why I'm such a geek about this stuff, but the scalene muscles are a similar formation to the intercostal muscles. They come from those same layers, the anterior, middle, and posterior scalene. They devolve a bit. They actually create channels within the sheet of muscle due to the nerves growing out, but they are embryologically of the same body muscle layer as the intercostals. So it's exactly what you say. When we need the intercostals for secondary breathing help, or the anterior scalenes, that's the only time they're necessary. And I just had a patient 2 days ago ask me this very question, so I'm glad you brought it up. Yeah, for all our viewers, you can have the scalenes blocked with a drug like lidocaine or Botox. You can have them removed, and it should not affect your life or your neck or your strength.
The strength of the neck just comes up from the paraspinals in the back, and rotational strength is created by the sternocleidomastoid. These ones come from the mastoid process of the skull
Very
down
strong.
to the anterior chest wall. And we don't touch those. They're not part of the story at all. It's the scalenes that we're after.
And those are bigger. The sternocleidomastoid is bigger
It's a
anyway
it's a
and
big,
strong.
strong muscle. That's right.
So we were talking about patients being seen by the wrong docs and stuff. So one of the things I talk about with our regular viewers and people who contact us is that awareness of TOS that the public now has access to through Google and social media and all these things that can spread something virally. I think that's made a huge difference. So for me, I wanted to ask you, what change have you seen over your career in the number of patients who have gone 5 years versus the number of patients who get a timely diagnosis?
I think they're more getting a timely diagnosis, quite frankly. And I think that population tends to be young people, often techies, who are surprised that they have these nerve symptoms and so on when they haven't had an injury and they're at their computer all day and all that stuff. But they're surprised that they have a problem at all. And I think one of the most satisfying anecdotes that I can tell you about was a young guy who was down here in San Francisco climbing one of the climbing walls, and he noticed that when his arms were up like this on the wall, his hands got numb and he couldn't grip things. So he said, "This is getting dangerous." And he called his dad, who was a retired thoracic surgeon from the Mass General living in New Zealand at the time, and this guy, this guy said, "Oh, you've got thoracic outlet syndrome. Go see Avery at CPMC." And he did, and we did his both sides, and he has had a total, complete reversal of all the problems. He didn't have the diagnosis long enough to develop shrugging, so he just did beautifully, and he's outliving his life in New Hampshire at the moment.
Unfortunately, a lot of patients we see don't have fathers who are retired thoracic surgeons from
That's right.
Massachusetts General who live in New Zealand.
Who happened to recognize what was going on immediately.
Yeah, lucky. That's lucky and good. I love those stories. So, computer use is one of those things I think locally
Yeah.
that it's just making this worse. I think the incidence is growing of TOS. What do you think? Are we just
I
recognizing it more? Is it
I think,
occurring more?
yeah, I think it's recurring. It's occurring more, Scott, because of the computer use and so on. But I think it's also being recognized more. And I'm thinking now of a recent case, a lady who is an ultrasonographer who was for 10 years doing this kind of stuff with her probe. And it may not be evident to people, but you have to push pretty hard on those things in order to
Mhm.
get a good image. So there's a lot of weird angulation and exertion of force in odd situations that goes along with that profession. And she was just getting more and more pain, but put up with it and kind of tried to got through it until 10 years went by and she was miserable and had to stop working. That's when she came in, got diagnosed and stuff. But I think um, had she consulted the internet, possibly she would have been given a clue. I don't know, but I think the internet has helped a lot when people are surfing around trying to figure out what's going on with me because I don't have a diagnosis and I don't understand what's going on. They start to get clued into this possibility, and then they might contact you through your website or somebody else, and through their exploration get to somebody who does understand and be able to tell them, yeah, this is what you got and here's what you ought to do.
I again will remind our viewers, please subscribe to us if you haven't subscribed. We're trying to hit the magic 1,000, and definitely hit the like button if you like what you're seeing here. I'm sure with Dr. Avery, you like it. So, Jim, we've seen a few baseball players, more than a few elite baseball pitchers being diagnosed with TOS. And
Yes.
whenever that happens, I will reach out to the reporter on ESPN and the team, and I never get through because these guys are such high value. They're owned by only a few doctors in the field. Um, we do get to see some of them afterwards, and you know, I hesitate, with such valuable properties, why we're not doing more imaging and stuff. But um, I try to view it as a positive that if someone famous is getting TOS, that the public sees a little bit more of it. And I believe now what you said is true. I think there are people who are recognizing the words when they see it on the internet. So hopefully that's a trend in the right direction for us.
Yeah, I think it is. And the ones that we've seen, as you may recall, Scott, are all left-handers who have a particular value because to be a left-hander and be able to throw 95 miles an hour,
Oh
that's
yeah,
a career. I mean,
think
that's
yeah,
a lot of
one
money.
one young man we saw whose dad called me while I was making dinner one night, and he said, "You don't know me. I'm an attorney in Palo Alto, and my brother is a professor at Emory, and he's been helping me search around the country for a TOS specialist. And today he said to me, 'You idiot! There's a specialist here in Sunnyvale, California.' So, and we helped him out. Really nice young kid, and I remember after you did the surgery, a few months later, he was playing soft throw with his dad,
Yeah.
and he said, "I can feel my fingertips."
Yeah,
I
that
didn't
that
realize
comment I remember forever. I can feel my fingertips when I'm throwing. Yeah.
he hadn't felt them in 10 years.
Yeah, that's right.
Yeah, it was amazing. So, tell us a little bit now about what the future of your practice is, and what evolution is going on, and how we can let patients know.
I'm going to be retiring completely at the end of June next year. And so, what I have planned to do is to pass the baton to another surgeon, a cardiothoracic surgeon named Peter Anastasio. Peter is more thoracic than cardiac, but I've known him for a long, long time and think highly of him because he's a fine human being and integrity and all that stuff, and he's smart. So he's often been in surgery with me because he's been interested in this for quite some time. And I more and more am telling new patients that if they are candidates for surgery, you may want to wait until Peter comes on board. And the reason I have offered that suggestion to them is because I don't operate and then walk away from patients. I'll see them a lot post-op to see how things are going. And if things aren't going the way we'd like, both of us, the patient and me, will try to direct them in a way that makes sense. So Peter is the same way, and I think you can't just do an operation and then call it a day with patients who have this condition because again, so much of the problem has to do with the muscle component, as I've said, and if they have issues about nerve changes as a result of the operation, I can be there to help them understand why it is and the likelihood of it getting better. So my practice, so to speak, would in this area is going into the hands of Peter coming the end of June next year. And already I'm starting to prepare patients for this change. And there are a few patients that I've seen chronically over the years, not so much because I can do anything more for them, but they've gotten confident in me giving them advice kind of in general, medical advice. So Peter's the future from our center who will basically do the same approach. He believes that this makes a lot of sense. He's very happy with the relatively non-invasive nature of this approach, and he's very happy with the results from this approach. So I think he is a true believer that you don't need to do a big thing. The one exception is if you got a cervical rib, you got to go up top. You can't do that one adequately from underneath. It's just too far away. But if you have a cervical rib, which may be combined with a typical first rib problem, that has to be addressed from the top, the cervical rib portion. But the primary first rib resection, I think, can always, and always is a dangerous word, but I would say 99.999% of the time can be addressed adequately and safely from an infraclavicular approach. So Peter would be doing the same operation, and
Right.
he's been around for a lot of them. Participating in the evaluation process. Have we done enough, with the finger on the stump and so on, moving the arm, that he will do that. So I think the quality of the work that he will do will be first rate.
It's great to hear, although it's sad for me personally and for a lot of patients to know that you're retiring. If I could just say that.
Thank you.
Um, so Peter, who I haven't met in person yet, but I will, he'll be doing the same procedure. Are there any other people you know of in the country or region that offer this procedure, this approach?
I'm sure there are. I just don't know who they are. And
Okay.
I think, Dick Sanders was our go-to guy at the first part of my career, and I think yours as well. And I would be surprised if he's doing it any differently than he always has, a supraclavicular approach and removing stuff in that way.
Yeah, Dick is a very, very nice man. He's been retired for several years,
Hmm.
um, or semi-retired. He'll still go in and observe and coach, but I
Hmm.
don't think he's doing the procedures himself.
Hmm. I think that's probably true.
Yeah. He was very gracious to us when we got to meet him in Colorado.
Yes, he certainly
Remember
was.
that? Yep. Um, so what do you think the future of TOS is? It's a broad question, I know, but shoot from the hip.
I would like to see more doctors recognizing that it exists, first of all, and I would also hope that people will come to find value in the kind of imaging that you have been doing all along, uh, to be able to appreciate when the nerves are being compressed and the vessels, but primarily the nerves we're talking about. Um, I think that is the, the the first step, and the essential first step is to, even as a physician, consider that that might be a possibility, and then to prove it by getting you do with imaging both with the arms down and the arms up, and being able to read when there is effacement going on in that situation that the arms are elevated. So it's the awareness of the condition, number one, spreading, I think is going to help a lot. It's a slow process, but I think, again, for reasons of, um, I think it's increasing incidence in the population with keyboard use and so on, and the internet as a source of information to learn about what it is, and also to see how is it worked up.
So hopefully awareness among both patients and physicians.
Yes,
So the keyboard causes symptoms and then helps patients find a solution. So the
yes.
keyboard giveth and the keyboard taketh away, I guess.
Hmm.
Excellent. Let's see if we have a question here that we can ask you from one of the viewers currently here. Herb, not Gugu Pa says, "Hi, thank you both for doing this. Thank you for viewing with us. When unilateral scapular pain is the most debilitating symptom, what is a typical surgical approach vis-a-vis the nerves you address, and do you always remove a rib?"
Well, I think from the question,
And yep, the further follow-on question. Let's go back to that. Is I accidentally posted a question before the chat. Your talk answered my question. That's great, Jim. You already helped them. My follow-up question is: if you are not one of the lucky ones to be diagnosed early, what should you do?
well, I still think it's appropriate to get seen by a physician who knows that the condition exists, and get worked up with a good thorough physical exam, looking for signs of nerve tension and so on, and follow that up by an imaging study of the type you do, Scott, where we are imaging both in the arms down and arms up positions, where we can then elicit both symptoms with the arms up and image in that position, and from that see compression of the nerve roots.
Excellent. Jim, do you have anything else to add? I want to personally, first of all, thank you for making the time to be with us. I know how busy you are. And as I said, it's a little sad for me, and I'm being a little introspective about the fact, thinking that I knew someday you'd retire, just like Tracy, but with a concrete date coming up, it's a little bit more real. So it's going to be a shame when patients don't have resources like you and Tracy around anymore. I'll just say that.
Well,
What do
thank you.
what do you plan to do with your future?
Well, I think I'm going to not stay um, attached to medicine much when I walk out the door. We have my wife and I are teaming up with another couple from the East Coast, and are going to explore life in France for a chunk of time in rural southwest France.
You'll have your own vineyard, I bet.
No, probably not. I think we'll just live there and start to get a sense for what's life like in Europe.
A few times I've visited with the family. It's pretty amazing there.
Yeah.
So count on us visiting you.
Definitely. Door's always going to be open.
Thank you. All right. Well, I hope everybody enjoyed meeting a true, respected, highly respected, experienced TOS surgeon and hearing about what's happened with TOS over the course of his career. Dr. Jim Avery's office can be reached. We can always give you the contact information through our website if you didn't catch it here. There we go. I'll remind you that I'm Dr. Scott Worden, the TOS guy. You can reach me through our website, tosmri.com. We also work with TOS Education, no spaces, .org. That's toseducation.org. We'll have another presentation, a live stream in 2 weeks with a speaker to be determined, and we will send out our emails to the usual people and the usual suspects. Again, if you haven't subscribed, please help us out and please hit the like button. Jim Avery, thank you so much. It's been a pleasure having you here tonight, and we'll see everybody soon.
Thank you, Scott. It was nice being here. Bye-bye.